Good greetings, everybody. This is the Public Health PBRN monthly meeting for December. We'll get started here in just a few minutes. Give people a little bit more time to get dialed in. And greetings, everybody. This is the Public Health PBRN monthly meeting for December. And we'll give people just another minute here to get logged in, then we'll get started. We can welcome everybody to the December edition of the Public Health PBRN monthly meeting. And it looks like we've got a pretty good crowd coming online here. So I think we can go ahead and get started. And again, just as a reminder, I think it always helps us if you can mute your lines during the call while you're not asking a question. That'll help us cut down on the background noise. And if you're on the web version of today's meeting, we'd encourage you to use the little hand raising signal whenever you want to ask a question or make a comment. If you can click that little man at the top of your screen that looks like he's raising his hand, we'll keep an eye on that and open the floor for you to ask a question or make a comment when that arises. So please feel free to do that. We've got another great agenda set up for today, starting off with our research in progress presentation, as we always do. And today we're going to hear from our colleagues up in the Massachusetts Public Health PBRN on some interesting work they have going, looking at food safety issues in local public health in Massachusetts. Some very interesting work. So we're pleased that Dr. Justine Hyde and her colleagues are going to share their work today with us. And I know that Justine has got some other things on her calendar for today, so we want to try to stay on time so that we can free her up shortly here. So let me go ahead and pass it over to Justine.
Can you hear me?
We sure can.
Okay, good. Hi, everyone. It's good morning here. I'm in California with my family, so if you hear little kids running around, you'll have to give me a little bit of slack. So yeah, our holidays have started here. But I am going to present today a little bit on, it's not research, well, I guess it's still research in progress because we're still analyzing our data. But it's data that we've collected as part of our Research Implementation Award. And I presented some of the findings from this research at a PBRN, I guess just about a year ago now. And so we're still cracking at it, hoping to get some papers out. But our team, Jessica Waggett, Lisa Arsenal's been our analyst, Lise Freed is an epidemiologist who works with us, Harold and Kathleen. And then our PBRN Research Steering Committee, there's a group of us that have been thinking about these data. Phoebe Walker is in the western part of the state, and she's a public health practitioner. Jeff Wilkinson is at the state Department of Public Health. Sandy Collins, Jim White, both run health departments in our state. And Mike Moore is at State Department of Public Health, and Cheryl Sabara is at the Association of Health Boards. So that's our motley crew that keep plugging away at some of these data and thinking about how to present them to our state. So I'm going to, I think if you've been on these calls, you know a little bit about the context of public health services in Massachusetts, so I'm not going to spend a lot of time talking about that today. But just a brief overview of that context of the study that we conducted, and then some analysis that we're doing now looking at food safety standards. And if you've looked at the literature in food safety practices or retail food safety, there's not a lot of it. And so a few years ago, there's a few more articles that have come out recently, but a few years ago when we were putting this grant together, there was very, very little to go on. And our call from Robert Wood Johnson Foundation was to look at evidence, the delivery of evidence-based practices, public health practices. And we were surprised at how little evidence-based there was around food safety practices. So I'll talk to you a little bit about our struggle in that area and what we ultimately decided to do, and how we're trying to look at the data and contribute to the evidence in this area. So Massachusetts, 351 boards of health. We are in a grand experiment trying to reduce the number of health departments, but I think most municipalities are retaining their boards of health at this point. So we still have 351 boards of health that are responsible for providing their state-mandated services. I'm happy to say that about a third of our municipalities are also involved in efforts for cross-jurisdictional service sharing. So we're trying to build some efficiencies by sharing services, and some of them are consolidating at this point, and some are starting off smaller and sharing a few services, and we expect that will grow over time. But with every municipality responsible for providing public health services, what ultimately means as well, there's a lot of local control over that. There aren't a lot of resources or efficiencies in how services are delivered. And in a lot of areas, public health services are barely delivered at all. And so one of the purposes of our study was to both get a handle on what our infrastructure looks like, and then try to generate some evidence about how the local context and the organization of public health services are related both to the capacity to meet core function-related performance standards and deliver some evidence-based practices or best practices in the area of retail food safety and communicable disease control. And our PBRN thought that if we could show that, for example, at some population size, you begin to see better quality services delivered, that would be an incentive or the evidence that was needed to move towards service sharing or other ways of delivering services in collaboration. So that was, really at the heart of why we actually conducted this study, that and the fact that we know very little about the infrastructure in our state. So I guess, yeah, also. We conducted a survey. That was our methods. We originally attempted to call and conduct by phone a representative from each of the 351 boards of health. In a lot of, we had I'd say we had sort of 3 layers of recruitment. The first layer was the willing people that participate in surveys or would with a little bit of encouragement. The second was a group that said, I am happy to do this if I can do it online or in a self-administered way, but I don't want to be on the phone. And so midway through, we created a self-administered version in order to increase participation. And then the last third is really a group that there's just really no one there. We have some boards of health in our state that they're all voluntary, but maybe someone checks a voicemail for the Board of Health on Tuesdays between 5 and 7 at night. And so reaching somebody in the Board of Health in some areas, short of parking ourselves outside of their houses, was pretty challenging. So we ended up having both telephone and self-administered surveys. And the surveys took about 45 to 60 minutes to complete. They were pretty long. And all of the responses were reviewed by a project manager for quality and completeness. For those that were self-administered, we ended up going back or emailing with people to fill in any information that they left out, and that did happen. Data were entered in an Access database, and we're analyzing it using SAS. And the survey covered a number of areas. We, in advance, collected municipal data so that people didn't have to go out and get that because it's accessible to us already. We gathered information about governance, the kind of public health services delivered, and we drew on the NACCHO profile survey for some of those questions. The workforce that's in place to perform public health services, funding, which actually ended up to be more complicated than we anticipated. Funding for public health services is very complicated. And then we created a capacity scale, drawing on a scale that already exists, the Turnock-Miller 20. And we modified that using NACCHO's operational definition of a functional health department. So I'll get into that in just a second. And then delivery of evidence-based food safety practices, which is the focus of the talk today, and communicable disease control practices. So it's sort of a broad overview of the areas that we covered in our survey. At the end of the day, after all of our outreach, we got about a 70% response rate, which was very good for our state. And this sort of gives you a map of just a visual overview. You'll see that in the western part of the state, there are lots of white spaces, and that's predominantly where we have very limited public health services delivered and virtually no resources to do it. They're also very small towns. And then in the south eastern part on the Cape and in the southern areas, there were people that just flat out refused. So the orange marks are refusals, flat out refusals, and the whites are just non-responders. So that sort of gives you a sense of what areas are represented in the survey, which is important for us in particular. So I'm going to just talk a little bit about how we created the retail food safety standards, because that will be the focus for the rest of the talk. There's very limited evidence base around best practices for retail food safety practices. And in our state, retail food inspections it's a primary public health service that's delivered. We do a lot of regulatory work, and it is the one service that is done most consistently, I would say. So there's a lot of interest in it. The state mandates that every retail food establishment is inspected 2 times a year, and that's pretty much the standard that they have to go by. There's no other sort of requirements or guidance on how it should be done from the state's, coming from the state. So our PBRN is interested in, I think anecdotally we know that 2 times a year. Retail food establishments aren't inspected 2 times a year in a lot of places. That the quality varies from a sort of drive-by inspection, 5 minutes of looks good, hi Joe, how are you, to, very high quality inspections, and so, we are sort of thinking about, well, when we asked about food safety practices, what measures are we going to use? And so we looked around a lot, and we decided on the FDA's food safety standards. They have 8 standards that they use, and I think I'll come back to that. So the food safety standards fall into a number of areas: training of retail food safety inspectors. So how are people trained, and how often are they retrained or have booster trainings? Inspectional service protocols that are followed. There's area standards around preparedness and response, one around compliance and enforcement, and that's really, do food inspectors have authority to issue violations? What else is in that? Is there a system to ensure uniformity among regulatory staff? So consistency and enforcement authority. And then there's a standard on industry and community relations and community education, one on resources to perform inspections, one on supervision and oversight, and then one on program assessment or monitoring. So we took those standards and we crafted our own questions. So we have about 20, I think we have 24 questions that we created, and we consider it more of a screener. I wouldn't say this is a thorough assessment of food safety practices, but more of a screener, high-level screener of, do you do some of the things that are recommended by the FDA? And we'll go back to our study hypothesis, was that municipalities with a higher capacity to perform essential public health services would be more likely to meet FDA standards for retail food safety inspections. So, I think hopefully that's a duh, that we would hope to find that. But again, there's not a lot of evidence for something like that. So what we did, we have 25 questions, 8 domains, 25 questions, sorry. So what we did was we created a scale from the data that we collected. Without any other evidence available to us, we gave every question was worth a total of 4 points. So there's a possible 100 points possible for this scale. And then for the analysis, we did a number of things, and we just basically looked at the quartiles at the end of the day. So low capacity to meet the standards, were municipalities that had a score of 0 to 30, and then, mediums 31 to 43, 44 to 54, and then 55 above. We didn't have a lot over 55, quite honestly. So, well, we got about a quarter was between 55 and 100, but they tended to be closer to the 55 mark. And so that's, this is, any input on our analysis strategy is very welcome. We're trying to think about how to synthesize this data and look at it in comparison to the capacity to perform essential public health services. And so in the last talk that we gave last November, we talked a little bit about how we analyzed our capacity, or our screener for capacity to perform essential public health services. And so it's a very similar strategy. With that scale, we had the 10 essential public health services, which you all know. We had a 25-item screening tool, which I already talked about. And then again, it was each item was worth 4 points for total possible of 100 points. If anyone has questions while I'm going on, please chime in. I don't know if I'm going too fast or not, but I'm happy to take questions.
And you can also use the chat function if you want to break in with questions.
Yes, I probably just won't write you back right but someone can help fill those. So I'm going to talk first about the capacity to perform essential public health services, because you'll see that that's related. It is indeed related to the food safety standards. So the capacity to perform essential public health services on that scale from 1 to 100, in our state, there was a mean score of 43.5, with the mean in the lowest quartile was about 22.6, and in the highest was 65.5. So pretty limited capacity to perform essential public health services, which we know about. There's like maybe 3 of our municipalities are even thinking about accreditation at this point. So we have a lot of growth potential in our state. When we think about factors associated with capacity to perform essential services, population size, and this is in some previous studies, efficiencies are found at around a population of 50,000. We have very few municipalities with populations of 50,000. So for us, it was around 26,000. And then related to that are serving in urban areas, high poverty areas is associated with capacity, annual municipal budgets, municipalities with elected boards of health. This is an area that people are pretty interested in. They're not really sure why that is. And then perceived understanding perception of the understanding that municipal leaders have of the responsibilities of local public health was a strong predictor of capacity. And then staffing, having a full-time director and staff. In our multivariate analysis, the strongest predictor was having elected officials who understood responsibilities of local public health and boards of health, and I think that probably is related to a lot of things. The greater understanding you have of responsibilities, the more likely you are to allocate money in the budget to perform public health services. There's probably more coordination in those municipalities between municipal departments, so work gets done in a different way. And then having a full-time director was also really important. So, and I present that because the same, there's a lot of similarities between the capacity to perform essential public health services and the predictors of meeting retail food safety standards. So in the analysis that we did for that, it was a population size of 29,000 or greater is where we started to see improvements. Annual municipal budget, annual local health department budget, all related. And here, in this analysis, it's having an appointed board of health. Again, we're not really sure why there's a difference between those two, but it's an area of interest. Local boards of health meeting regularly with officials, and also, again, the chief executive having a good understanding of public health responsibilities, having a full-time director, and then the capacity to perform essential public health services was the strongest predictor of meeting food safety standards. So that's the good news, that there is a relationship between capacity and delivery of evidence-based practices. We wanted to see that. We expected to see that. We did. And then again, for us as a PBRN, we know from this analysis and the previous one that one of the strategies for improving the quality and the delivery of public health services will probably be an outreach effort to elected officials, really with a target of trying to increase their understanding what is the importance of public health services, what are the responsibilities, and what difference can it make. So, we're sort of thinking through how to do that. So I see a question about how their understanding was, how we measured officials' understanding of local boards of health responsibilities. Um, there were two simple questions. The most straightforward was, to what extent do you think that your chief executive, so that would be a mayor or town administrator, understands the responsibilities of a local public health department or a local board of health? And then that was a scale from, very limited to a great understanding. And then we also asked about frequency of meeting with the council or administrator, board of health, board of selectmen, or the chief executive. So because the chief executive, the mayor, or the town administrator usually plays a different role than the board of aldermen or the board of selectmen or the city council, we asked separately about those two. And so they were pretty straightforward questions, and it was just a perception of their understanding. And whose understanding would be a good next question. And the people that, by and large, the people that filled out the survey were either the chair of the Board of Health, if there was no public health director, or the public health director, or commissioner if there was one. Let's see, I'm almost done here, and then I'll get at some of these questions. So I have very limited capacity to talk about, about this graph, but I know our analyst thinks that it's really cool. So I wanted to show it up for those data people on the call. We looked at the association, a visual association here between capacity and food safety. And she was very excited that the food safety score and the capacity score, you see a really nice clustering. And so we're thinking that this will go into one of the papers that we create. And then I'm just going to sort of end with, this is our last data slide. This is the slide that we're really thinking about how to use for our in our PBRN. What we did is, one question that we had was, well, when we look at individual scores for each of the standards, what really differentiates municipalities that are scoring higher from those that are scoring lower? And so what we found, really, when you look at this assessment one, so do you have a system in place to self-assess your retail food inspection program? So that means, like, do you review forms for quality assurance? Do you examine consistent compliance and enforcement activities? This was, this really differentiated municipalities from one another. And then the second biggest difference would be the industry and community relations. So does somebody in your municipality participate in task force or advisory committees on food safety? Do you communicate with the public regularly about food safety or hold food safety training programs for retail food establishments? And then, there's some differences in compliance and enforcement and preparedness and response. So, we thought this was really interesting, and I think what we struggle with a lot is in any of the monitoring and oversight and consistency of practice in our public health services, and so we're interested in how to use this information as well. And I think this is where we see a real benefit of cross-jurisdictional service sharing, is that you're able to move from one person performing services to multiple people where, there can be a little bit more oversight potential. So I think in summary, there's the capacity to perform essential public health services to meet food safety is associated with capacity to meet food safety standards. All the things we talked about are associated: population size, staffing, things that we would expect, the understanding of the local board of health, and then that we found that there are a few standards that really differentiate capacity. And so our next steps are we're still trying to get a manuscript finalized. I'm the bottleneck on that, so soon I'll get that out. We're thinking about how to disseminate this through our networks locally, and then working with our local public health institute for targeted professional development in certain areas. And then the next thing on our survey that we're tackling is communicable disease control. So that is where we are with these data. And Liz out there, Glenn, I don't know if you want me to just read through the questions that came up on the...
Yeah, why don't we go ahead and do that,
or
and then
open it up if people want to ask it.
Yes, I've also
exactly,
opened
yeah.
the line, so everybody can speak right now.
Hi, Justine. This is Elaine.
Hi, Elaine.
Connecticut. Hi. Great presentation, and I want to thank you again for your support as we were working on our proposal, because we're looking at assessing capacity to perform essential services in Connecticut as well. And I was just really curious about two things. One, that you're doing additional research, building on the essential service capacity that you designed, correct? And looking at the connection with these different capacity levels or performance areas like food safety.
Mm-hmm.
And you're continuing to you're using the same precise tool that you developed with the 25 items?
These were all in the same, all these questions were in the same survey.
Okay.
Yeah, so we had a section on the capacity to perform essential services, and then the next section were these questions that we created using the FDA food safety standards.
Okay, so you're going to do the same thing with the communicable disease study.
Yeah, so we'll
be comparing capacity on communicable disease or performance on communicable disease activities with the same indicators of capacity to do the essential services.
Well, I'd love to say yes, but the communicable disease control, those were even more difficult to come up with.
Yeah.
At least the FDA had some standards.
Right.
We really created, we drew out a lot of things for our communicable disease control, and I think we'll probably need to do a different kind of analysis.
Mm-hmm.
For.
No, but my question, and I'm probably not being clear, is you're going to continue. You're still continuing to use the results of the original assessment of the essential service capacity.
Yes.
Am I being clear? Okay. I was just wondering if you were thinking about altering that assessment, or if you're sticking with that. Okay.
No, we're gonna. Well, we've already collected all these data, so now we're just analyzing them.
Well, I just another comment. I think that the finding around the importance of elected officials' understanding of public health with capacity and performance is so significant that I don't know if you said this already, but you said you were going to talk about how there could be more education or interaction with elected officials around public health, and to build more support for public health in that group. And have you discussed doing that at a national level with U.S. Conference of Mayors or governors, or they all have their associations?
Yeah, we're just starting to talk about that. I mean, right now we're just trying to get our Board of Health members to buy into getting trained on what their responsibilities are, which is challenging. So one of the things that we started doing was making some presentations. There is a regional or there is a conference every September that the elected municipal leaders go to, and it's focused on regionalization, because in any governmental sector. So a lot of municipal leaders do go to that conference. So locally, we're trying to tie in some presentations to, and at leverage opportunities where they're coming together. But yeah, I mean, it's on the docket for us to talk about in our next couple of meetings. So I don't have any great ideas yet, but we're certainly open if anyone has had a successful. I mean, there are campaigns that have already been developed. What is public health? This is public health. That that are available, but sending them websites and links, and that just is not. Uh, that strategy probably won't work.
Right.
So we need something else, and they do talk with one another. So yeah, I don't have a great answer yet, but I hope to.
I don't mean to. I mean, your experience is just making me think. I think reminds us of really the importance of like doing this nationally. It's something that the PBRN nationally, all PBRNs I think would be interested. At least I can speak for us in looking at. And it also that recently we were asked to kind of to weigh in and try to provide some useful information to policymakers. Lisa Pappas, what is the name of the woman? I'm blanking on it. They were looking at various studies that had been supported through PBRN on the impact of economic decline and cuts in funding on services and so on. And it was difficult for us to come up with ways to communicate what we were learning. So it's kind of related. It's not the same as what you're talking about, but I do think it might be something we want to really have a discussion about at the next PBRN group meeting.
You can just direct them to our state laboratory.
Now.
Oh, yeah.
Well, I mean, that's an impact of an economic, budget cut.
Yeah, absolutely.
So, again, it's that monitoring and oversight function that we know is really important, and it gets cut.
Well, another part, I mean, there's also tremendous interference in regulatory functions from, legislators people. So,
yeah.
I mean, it definitely is a tough group.
There's a quick question from Paul that says, does the Board of Health have the authority to hire and fire the health director? It does vary by town charter, but generally speaking, the elected boards of health have the hiring, firing authority, and appointed boards of health, that would be the chief executive that usually does that.
And thank
generally
you.
Speaking.
And, yeah, this is Paul. Thanks very much for that. So in follow-up to that answer then, can you comment further on the differences that you saw when you looked at issues pertaining to elected boards of health versus appointed boards of health?
Yeah, I mean, they're different. So, I mean, we're a little perplexed by it. So the capacity to perform the 10 essentials, that was associated with having an elected board of health. And with the food safety, it's an appointed board of health. I honestly don't have a good answer. We don't really know why that is. Yeah, we haven't done any more specific analysis looking at elected versus appointed boards of health and, sort of played with the data in those ways. But we do have an intern that we're thinking about hiring that is interested in that. So, yeah, I don't know. I mean, I guess the other thing that I could add is that they're just really, I mean, in the because we have these categories of elected and appointed, what that means at the municipal level, it just varies too. I mean, one way is, kind of cutting the data or categorizing municipalities, but within that appointed Board of Health category, there's a lot of variation in how that appointment happens. Whether it's the Board of Selectmen or the Aldermen or the City Council, or if it's the Chief Executive, or how that happens, it's very different.
Any other questions? It looks like Golzar had a question there. Golzar, do you want to?
Justina, this is Gulzar. Yet another really impressive presentation, very interesting. I was just curious if you included both measures of the elected officials' understanding in the multivariate analysis, or did you include one of them, or if you did include both, were they combined somehow? I was just curious.
Yeah, so for the two measures being the Chief Executive and the board, those two?
Yeah.
Yeah.
I thought you said meetings, number of meetings attended, and the rating scale of understanding.
Yeah, we threw everything in there, and so it was the Chief Executive. So we didn't combine them to create a single measure, and one of the reasons we didn't combine the understanding and the frequency, and I think it's because of the way we maybe asked the question, but one of the options, so I don't have the survey in front of me, but do you meet with them once a month or more, 9 to 11 times a year? So there were categories that we broke it down to: less than once a year, less, or as needed. And so in the as needed category, I think there's both a mixture of not meeting very frequently because we don't feel like we need to, and I have a great relationship with our Chief Executive, and I meet with him whenever I want to, or her whenever I want to. And so there was a real mixture of what that meant for people. So we didn't feel like we should combine them. So we kept them separately and looked at
yeah,
what
no,
happened.
that's great. And so all or most of them were significant?
I'm sorry, can you say that one more
Or
time?
all of them, or some, or most of them significant predictors?
Yeah, it was the Chief Executive. For the capacity to meet essential public health services, it was the Chief Executive's understanding, so the mayor or the town administrator. That was the strongest predictor. And then for the food safety, it was both.
Okay, thank you.
Excellent.
Right, any other questions? Yeah, so we're plotting through it. We're really trying to think about the best way to synthesize these data, and our focus is really to look at how these things relate to the capacity to perform essential services. So it's been fun, to think about and think through, and I think we'll be looking at these data for a while.
Yeah, this is fantastic, Justine. Thank you so much for sharing these findings with us. I was also going to remind folks, and you're obviously working on this paper, but you had another paper recently published in the current issue of the Journal of Public Health Management and Practice that I think, correct me if I'm wrong, but that focus is more on your capacity to perform essential services, that set of measures, and the factors that explain variation, that set of measures. Is that right?
Yep, yep.
Yeah.
So
if
that
you're
was like the brief overview that I gave. I kind of threw that in there just as context, but yeah.
Excellent. Yeah. So folks who want more information on that, I definitely recommend that paper. That's a really good work again by Justine and her colleagues. And we'll look forward to the next paper to come out. This is really great work.
Thank you.
Thank you, and thanks again, Justine, for taking time out of your holiday schedule to be with us today. We appreciate it. With that, I think we're ready to move forward into the next iteration of our agenda. Let me see if I do. I have control of the slides. So we wanted to give some updates, some other updates around PBRN research first and foremost, and to start off, we need to take an opportunity to congratulate our first cohort of public health PBRNs. They are now 4 years old this month. The networks in Kentucky and Massachusetts, in North Carolina and Washington. Those 5 networks started up with our program 4 years ago this month. So a great milestone, and obviously, as we heard about today, some great work coming out of our older siblings who started in this program with us. And that means next month, January, will be the 3rd birthday of our second cohort of networks, 7 that came up in January of 2010. So an important milestone, certainly. A couple of other updates just on research projects. Our multi-network research study, the IMPROVE study, we're continuing to make progress thanks to the great work of the 6, really 7 networks that are actively participating with us in that project. We shared with you last month that we did hone in on a final set of core measures through the measurement selection Delphi process last month, and this month networks are rolling into data acquisition mode and are finalizing their data acquisition plans and preparing to get into the field with both acquiring secondary data for those measures as well as doing some primary data collection for most of our networks. We're very excited about that. And again, for the networks that are part of that, I know that you all are working on your data acquisition plans. We've already heard from several networks around those activities, thanks to New Jersey and thanks to Minnesota for your good thinking already on those issues and the feedback you've given to us. And we look forward to hearing from our other networks as well as you move forward with those data acquisition plans, and then we can get in early in 2013, get started with data collection. So we're very excited about that. We also we've got 8 PBRNs that are working through their RACE studies. These were the Research Acceleration and Capacity Enhancement Studies, the RACE studies, which were for the most part supplemental awards that networks received back in the fall of 2011 in some cases to add a new component onto their study, an existing study, particularly a component looking at disparities in public health delivery or looking at some issues of diversity. Or the other option that 2 of our networks took was to add on a new methodological component or test a new methodological strategy within an ongoing PBRN study. So those 8 awards are continuing to progress. We actually had at least one of our networks complete their RACE award. Most of these awards are 18-month awards, and so I think most of our networks still have another 6 months or so of work to go on their RACE award. But I know that our Washington network finished up their RACE award a month or so ago. We got some of the final research coming out of that project. That was a project looking at disparities in the delivery of public health services, in particular looking at the effect of the economic downturn on service delivery activities and testing for differential effects on communities that have disproportionate shares of racial and ethnic minority populations. So some very interesting work out of the Washington network. So stay tuned as that network begins to disseminate more broadly the results of that study. They've done some presentations recently this winter at some state and regional meetings, and we'll be doing some more dissemination and publication work off of that shortly. So that's happening. Our race awards are continuing to progress. Quick strike studies. I think last month we shared with you the kind of full list of 4 quick strike awards that were awarded in our current cycle. One of those quick strike studies has actually already completed, and they already have findings that are beginning to be shared through research briefs and manuscripts in preparation. And that was the first quick strike that we funded in this round. The study up in our Wisconsin network that is looking at this issue of shared service arrangements between local health departments. Some very interesting findings there. I found really a very high prevalence of shared service arrangements already existing in the state of Wisconsin, as well as a number of planned arrangements that are taking place. So stay tuned to hear more about the findings from that study that has recently wrapped up in Wisconsin. Our other quick strikes are still underway and in progress, and we're eager, and we'll give you updates as we start to see findings coming out of those other studies, looking at topics like consolidation of health departments, looking at topics like the cost of delivering core public health services, and in our Georgia network, looking at issues around health information exchange between public health and healthcare providers. There's some interesting studies underway there. Finally, in terms of PBRN research updates, we wanted to give you an update that the next iteration of the NACCHO profile survey, the census survey of local health departments, is teed up and ready for launching. We'll be going into the field here shortly. We wanted to let you know that that's obviously an important data source for many of us who work in the field of PHSSR, and a number of our PBRNs have made use of those data. We're hoping that we can call on you, our PBRN networks, to help with facilitating and prompting responses to the NACCHO profile this next round over the next couple of months. And so you'll be hearing from us and likely from NACCHO as well. NACCHO likes to use a strategy, has found it helpful to use a strategy of having some key champions in each state who are willing to talk about the survey in the field with their networks, and to outreach to some of their colleagues to prompt response rates. And so again, our PBRNs have been helpful in doing that in the past. We hope we can call on you to do that in the future to help over this next couple of months to help with the NACCHO survey effort. But just wanted to let you know about that. Any questions or comments, thoughts on those updates, or any other updates that folks want to share about research projects happening in your networks? Hearing none, we can progress into the next item of our agenda, which relates to funding and sustainability efforts. Obviously, an important issue for all of us in thinking about how to sustain the great work that's happening in your networks, how to expand and diversify your funding sources and research projects. We did want to just start by giving a reminder of a little guidance document we put together a couple of years ago that is on our website, and there's a link here from this agenda on just some general tips for building up your funding sources and thinking about sustainability of your networks. It's really important, particularly as we have networks that are becoming into their third and fourth years. It's really important to be thinking strategically about how to make that transition, how to diversify your funding sources. And there also are some good opportunities, and some that we'll talk about here in just a minute. But thinking ahead of time, it's not just a matter of of putting in a grant when you see that call for applications. You've got to prepare for making your network competitive, making sure that you're getting publications and other dissemination products out there to establish your track record in an area, and to build up the qualifications of your network. So you'll have a strong resources section of your grant application. So you'll have your investigators that are part of your network will have have strong biosketches that show they're publishing in areas that are relevant to the topic, and show that they have tangible research collaborations with your PBRN. Those kind of things that that can't turn on a dime. You need to be thinking about ahead of time. Important to keep in mind. And again, that the brief that you see here, this link might be helpful. We developed it a couple years ago, but it's always good to think back on some of those strategies and how you might capitalize on them within your network. But thinking specifically about funding opportunities, we wanted to talk about a few of these items. We did just in the last week get notice that the Agency for Healthcare Research and Quality, AHRQ, has put out a notice of their intent to publish a series of new funding opportunities in the area of comparative effectiveness research, CER, and PCOR, patient-centered outcomes research, to be released later this spring. And so you can go on the AHRQ website or check the latest, the December edition of your PBRN newsletter, which will be coming out in the next day or so, for the link to those specific funding opportunities. There's 5 or 6 of them, including smaller scale awards, larger scale RO1 style awards, some career development awards. They're targeted at junior investigators who want to build their capacity in these areas. And again, as we've talked about at the last skill building webinar a couple of weeks ago, there really is an opportunity to get projects funded in this arena that focus on public health strategies and public health delivery systems, not just the healthcare, clinical care arena. So you may want to take that into account and take a look at those opportunities from AHRQ. In terms of RWJF funding opportunities, again, many of you we know have just been through another cycle of submitting applications to RWJ. It was just 2 days ago that the deadline for the latest round of investigator-initiated research projects in public health services and systems research, that call closed earlier this week, and some exciting funding opportunities. Obviously, through that call, we'll stay tuned about the results of that and keep you informed about the results of that shortly. In terms of other RWJ funding announcements, I know there continues to be a call out through the RWJ Health Policy Research, Health Policy Scholars Program to fund policy-relevant research in the health and healthcare arena. Again, check our newsletter if you're interested in that one. I think that's got a spring closing date. We got notice just this week of a new funding opportunity out from the Public Health Law Research Program, specifically for dissertation awards in the PHLR arena. So if you have students and junior colleagues working in your network who've got an interest on a project that has a legal angle, that's a really good opportunity. So you want to check that out. The PCORI funding opportunities that we've talked about. We talked about it again at the last skill building webinar. The second round of funding for PCORI just also closed earlier this week. I think unfortunately it was the same exact day as the RWJ closure. So some of you I know were really scrambling this week getting grants in. There's going to be continuing array of PCORI funding rounds as we go out over time. I think the next round of applications will be due in the spring of 2013 for the PCORI grants in comparative effectiveness research and patient-centered outcomes research. So keep an eye out on that if you're interested. Again, that's the real growth area in the federally funded health research arena right now. So So keep an eye on that. You may also be interested that earlier this week, PCORI released the applications that were successful in actually being funded out of the first round of PCORI grants. And so you may want to check out that list as well to see what kind of grants actually got funded in the first round of projects. And there certainly were a couple of prevention-oriented projects funded, including we got one funded here out of the University of Kentucky that involves looking at prevention delivery in the cardiovascular arena that actually involves some of our health departments here in the Appalachian region. So not quite PHSSR, but pretty darn close. And so you may find that interesting to take a look at what got funded in the first round. And then finally, there continues to be some interesting NIH funding opportunities that have relevance to PHSSR. Again, check the newsletter. The Health Disparities Center in particular has got some FOAs out now that are relevant, looking at health policy and some other arenas, that, other opportunities in terms of strategies for reducing health disparities in particular. So you may want to keep those on your radar. So that's all for funding. I'll pause and see if there are any quick questions or comments on that before we move on. We're hearing none. Oh, yeah, go ahead.
This is Julie from Colorado. I wondered if you've heard anything more about the proposal that was being coordinated through the CTSAs.
Thank you. I was going to mention that, and I slipped my mind, but thank you for mentioning that. That is in the final stages of being ready for release. So we have been working at our coordinating center, have been working with our colleagues at NIH who run the CTSA program, the Clinical and Translational Science Award program, to develop a jointly sponsored call for research to be conducted in the area of PHSSR, but to be conducted through CTSA-funded institutions, clinical and translational science funded institutions. That will be released, I can't tell you exactly, but I can say in the very near future, not before Christmas, but shortly after that. So that is coming out. Stay tuned for that. We're really excited. We actually talked about it a little bit last month when we had the, back in Washington, we had the meeting of the Comparative Effectiveness Research Key Function Committee of the CTSAs, also met jointly with the Community Engagement Key Function Committees, and we actually talked a little bit about this, that this was coming down the pike there, so we started trying to pump a little bit. I'm not talking out of school here. So that announcement is coming. We will make sure that everybody in our PBRNs gets that announcement and are well aware of it, because many, if not most of you in the PBRNs have a connection to a university that's a CTSA-funded institution. And so we're aiming this at you, and to give you some leverage and some opportunity to collaborate with your CTSA colleagues and get them interested in doing some public health-oriented translational research as part of their portfolio. So that's coming, Julie. Thank you for reminding me. I had intended to mention that again.
Thank you.
Glenn, hi, this is Elaine in Connecticut. You had mentioned earlier the NIH RFA or whatever it was around for the health policy research centers.
Yes.
Were you speaking specifically of that? I can't remember the number of the RFA, but it was transdisciplinary.
That's it. Yeah, it'll be in the newsletter again. We're going to try to get out tomorrow. It's for transdisciplinary research centers that focus on studying the use of policy in general to reduce health disparities, whether they're health policies or other kind of policies. It's a U54 mechanism. So it's kind of a center grant mechanism that, so a large award that can house multiple research projects within it, along with a number of supporting cores. They're especially interested in projects that involve collaboration with government agencies like state and local health departments, as well as collaboration with.
We're familiar with that
Okay.
that fall. We had a kind of a preliminary conversation here with some partners in Connecticut, and we're probably not, I mean, the timing, though, on pulling that together is just really awful. It's due January 13th.
Yeah, I think it's Jan
Like that,
15th.
it really felt like a kind of smack in the middle of recess. But well, plus there were some other. I was just wondering if you knew of any initiatives to submit applications. They're only funding too.
Yeah. I mean, I don't know a lot, other than I can tell you that this is the second time we've seen that RFA. It came out for the first time back in the summer with similarly a very short turnaround time, 30-day turnaround time. They were planning on funding only 2 last round, and they funded 3. And now they've reissued it. So this is obviously a major area of interest for the foundation. This may not be the last time we see this RFA. So, we've seen this before. We saw this back in the summer. It is the challenging thing with it is it's tight turnaround. They're releasing it and giving you 30, 45 days to respond to a big grant.
It's a big application, but it's also, it requires quite a bit of groundwork to build a collaboration to even put in the application. I mean, presumably you have some collaborations that you're starting with, but still.
Yeah.
I was curious if you knew of anyone who was doing it, and already, I mean, it would be interesting to look at the centers that are currently funded too, that were funded last year.
Yeah, I did take a look at that because actually we're putting in an application from Kentucky and some of our partners in the Appalachian region. So I happen to know a little bit about this because I'm writing that grant right now.
Okay.
But I did look at who was funded last round, and you can get that off of the NIH reporter. And it's UAB was funded to collaborate with some partners, in Alabama. A partnership between Emory and the not Meharry, but the historically black medical school that's also in Atlanta.
Morehouse.
David Thatcher.
Morehouse?
Yeah, they were the second one funded. Thatcher's the PI on that one. And the third one, I can't remember who the third one to be funded in the first round is, but it's on the NIH reporter. You can see the project summaries and their research projects and who their collaborators are. But you're right. You got to have these collaborations already existing, and that's why I think
So they're regional too. They were focusing on pretty large areas.
Absolutely. Yeah, they want a regional focus. So so it's worth taking a look at. My guess is we may see this come out again, just like we saw it in the summer. It's obviously an area of interest. And this is one of the centers that's not taking the budget cuts like a lot of the other institutions and centers at NIH, not nearly as severe. So, and it's studying, health disparities, which we know are, a major area of interest for our public health community and PBRN. So, worth taking a look at.
Thank you.
Yeah, and I'd be glad to follow up with you offline, Elaine, if you want to talk more about that.
Well, I don't know that we're going to, it's unlikely. I think it's probably nil now for us here. But I know that there's a New York, there was a group in New York that was trying to pull something together. And actually, I don't know if Justine is still on the line, but we had communicated with Justine about the Massachusetts PBRN, because it just seems to me it would make sense if there are states with PBRNs in these regions that could come together. We might be able
Absolutely.
to.
Absolutely. I think that's the right kind of strategy.
Can you please send out the link for that call?
Yeah. It'll be on the newsletter. It was on last month's newsletter too. If you've still got November's newsletter, it's there. It'll be on December's newsletter that we're going to try to get out before the end of the day tomorrow. Okay, I know I'm behind schedule. I'm making Lizette nervous here. So let's move on to dissemination updates. And we've had a lot of dissemination activity over the last month through our public health PBRN. So great work. Wanted to mention that we do finally have the Frontiers special issue out that features a number of good studies from our public health PBRNs, particularly studies looking at QI and evidence-based practice. A really good issue. Thank you so much to the 5 networks that contributed papers for that issue. I know it was a tough slog getting those through our peer review and getting edits in place, but we're really, really happy about that. I also want to call people's attention that with this issue, we introduced a new feature of Frontiers that is actually authored by our colleague Paul Irwin here from University of Tennessee and the Tennessee PBRN, focusing specifically on examples of research to practice translation. So you want to check in on this latest issue of Frontiers to see Paul's very good article on research to practice translation, as well as the great pieces from 5 of our networks looking at QI and evidence-based practice studies. So again, a great piece of work.
Glenn, this is Paul.
Sure.
Could I toss out a shameless commercial, please?
Oh, absolutely.
Not to draw attention to myself, but to draw attention to the column, because I would think that the people on the phone would be able to contribute stories to that. So the whole focus is on translation of research into practice. So if you have a story, if you have an example to provide that we could talk about, please give me a yell. Just shoot me an email, and I'll set up a time to talk with you by phone, and would love to put something together. It's really focused on just getting the word out about how this is actually done. Thanks.
Excellent. Thank you, Paul, for that plug, and thank you for leading that effort, that new feature of Frontiers. We've got some great opportunities for dissemination at some national meetings coming up. You know that NACCHO has had their call for sharing sessions out for a while. They have extended that deadline through Sunday at midnight. So if you don't have an abstract in yet for the NACCHO annual meeting and you've got an idea, you've got till Sunday night as you're wrapping up those holiday presents to get in a sharing session proposal. And I've heard from our colleagues, from Bobby Pestronk and Carolyn Leap, they really do, they've got, again, that research track at NACCHO. They really do want some strong proposals. They really do want to hear from our public health PBRNs there. So if you haven't yet, you've got a few more days to get an abstract in, a sharing session proposal in. It'll be in Dallas this year, in July. The Keeneland abstract call is open through January 7th. Obviously, we want all you to be at Keeneland. We're going to have our grantee meeting again there. Great chance to present your research, so we strongly encourage you to get an abstract in there. Deadline is January 7th. Academy Health Annual Research Meeting. The abstract submission process is open through January 15th. This is the leading research meeting for health services research, and we also have our public health services research interest group meeting in conjunction with that as well. It's in Baltimore this year. It'll be a great meeting given the health reform discussions and all of our colleagues down there in the D.C. area. So get an abstract or even a panel proposal in for Academy Health. Those are due January 15 for the main research meeting. And also check out the interest group call for abstracts as well. They typically have a somewhat later deadline, although I haven't checked that out yet. So you can check that out on the website, and we'll remind you of that again next month. Our AJPM theme issue on PBRN research is still in progress. Now that we have the special issue on Frontiers out, AJPM will be moving forward with getting our theme issue into production. Again, we have this special relationship with Frontiers that allows us to publish brief papers in Frontiers, and then those papers can get expedited review when they're submitted as full-blown manuscripts in the AJPM. And we've been developing this theme issue. We've got 5 papers in that theme issue from our PBRNs. So you'll be hearing from us shortly about the next steps in that process. We need to get those papers uploaded and into production at AJPM here, and we can do that now that we've got the Frontiers issue out and the journal is up and rolling. So that's moving forward with a release sometime in 2013. We'll keep you posted on that release shortly. And then finally, we have a new React podcast that's scheduled for January. Anna, are you on? Do you want to say anything about that?
Sure. Actually, the new React podcast that we'll be launching in January features today's speaker, Justine Hyde. She's talking a little bit about what they found is working in cross-jurisdictional sharing in Massachusetts. So we're looking forward to getting that out there. We're just in the post-production stage right now. Should be out probably mid-month.
Fantastic. So this is all exciting news. I will say, just briefly, we're increasingly stressing our ability to get findings and policy implications out, particularly to our federal policy audience. Elaine O'Keefe was alluding to a call we made to several of you a few weeks ago because of a briefing that I did with some colleagues at Academy Health, a briefing for the White House Office of Management and Budget, exactly on our research that's happening and what we're learning about the public health system and how it's responding to the economic recession. On the basis of that, they've asked me to come back every 2 to 3 months and give updates of research in progress. This is to the White House Office of Management and Budget folks. These are the folks who put together the president's budget and who monitor our federal programs. So we've got an audience of policymakers. As you have findings like the ones that we heard from just today from Justine, let us know because we've, obviously we're on the precipice of a lot of change in the public health system, its financing and its delivery. And we want to make sure that our research coming out of your networks can play a role in that decision making. Okay, I know I'm running behind, but I think we're up to our Grants Administration Corner. So let me turn it over to Lizette.
Thank you, Glenn. Thank you, everybody, for being here this afternoon. I'm not going to take a lot of time, but I do want to go over these travel policies because these differ somewhat from last year. So I just want to update you. We have new policies that we formed in conjunction with the Robert Wood Johnson Foundation and the University of Kentucky policies, and we want to make sure that you're aware of these. So for the grantee meeting in April 8th, which is a Monday, and then the morning of the April 9th, the coordinating center will cover the cost of travel and lodging for only one representative from each PBRN with active RWJ funding as of 2013. So this means if you have a race grant, an improve, a quick strike, and then there are also some RIAs that are ending in 2013. Those will be eligible to send one representative from each of the networks to the grantee meeting. We will cover travel costs for each designated representative. That'll include airfare, a 2-night stay at the conference hotel, and I have April 7th and 8th because the meeting starts early on Monday the 8th. Cab fare, a small per diem to cover meals that are not included in your conference registration. Now, in order for these things to be covered, the network has to provide to us the name of your designated representative by March 1st. And I know this is a little bit different than last year, so we're really stressing this. Center-funded travelers who have one or more abstracts accepted for presentation at the Keeneland Conference, which starts the afternoons of the 9th through the 11th, might be eligible for support for an additional night stay on a first-come, first-served basis, depending on our availability of funds, and we will be able to make a determination of that closer to the actual meeting. Also, this is another change. All center-funded travelers will be required to book air travel through the University of Kentucky's travel agent. And we are going to provide, whoever that representative, each network's representative is, we will provide that representative with full details on how to do these bookings. And again, we have to have those names by March 1st. Again, as far as the hotel, the 2-night stay will be paid directly by the National Coordinating Center, so you will not pay the hotel and then be reimbursed. We will pay that bill for you. And if you are planning to stay for additional nights through the Keeneland Conference, then you will have to cover those on your own. This information will be included in our December newsletter, and we are also going to send out various reminders before the March 1st deadline for designating your network representative. So if you have any questions, please let us know, and we will provide you with additional details. That's it.
Fantastic. Thank you, Lizette. I was just realizing, actually, we're right on time. I thought I was running behind, but we're so, thank you. Yeah, so as you've got questions, I know this is, we're having to be a little bit more deliberate in our travel budget because we're these are lean times. We had to kind of restrict our travel funding a little bit because of the foundation's guidance. So but let us know if you've got questions or comments or concerns about travel or about the upcoming Keeneland conference, about the grantee meeting, etc. But don't forget, abstracts for that conference for Keeneland are due on the 7th of January. So so make sure you get an abstract in. You're going to be with us here for the grantee meeting anyway. Use this as an opportunity to present the great work that's happening to this larger field of PHSSR.
Glenn, this is Nancy from North Carolina. I have a question. Keeneland, do you take panel proposals for Keeneland?
I can field that one.
Great question. Did you want to field that one?
Yeah, I need to field that one because they're using a different abstract submission process this year. So I just want to make sure that we're clear. They welcome panel submissions. The only caveat to that is that each paper presented in the panel will need to be submitted as a separate paper with a note somewhere in the narrative that it is going to be part of a specific panel. So I would recommend naming your panel and then within the narrative and maybe even in the subject line if there's room, noting that it's part of this panel with these other papers and list it. I would even go so far as to list the other authors involved just to be safe. They are using a different online management system and we don't want anybody to fall through the cracks. That helps?
Yep, thank you.
So it's kind of analogous to what you have to do at APHA, if you want a panel. You have to kind of make sure that you indicate which abstracts go together. Fantastic. Well, a few other reminders, upcoming meetings and events. We will have our next scheduled PBRN monthly virtual meeting on January 17th. So stay tuned for that. Our Kentucky Public Health PBRN will be doing the research and progress component in January, and I promise you're not going to want to miss this one. Some exciting results coming out of the network here in Kentucky. February 4th and 5th, Academy Health National Policy Conference in D.C. Always a great conference for those who might be interested and available to go to that. Also, every year with this conference, on the morning of the second day, the Tuesday the 5th, we always do a public health interest group breakfast session. It's early. It starts from 7, runs to 7 to 8:30, where we have bring in some national speakers and kind of talk a little bit about PHSSR and what it means to health policy as part of this larger meeting. So it's a great meeting if that's on your schedule. In March, you can see the Environmental Health National Meeting takes place in Boston. Obviously, a lot of great public health research and practice and policy happening in that conference as well. A number of our PBRNs have environmental health related research happening, as we heard from Justine today, and also our improved study looking at environmental health service delivery measures. So that's a meeting of interest. Again, our annual grantee meeting coming up on the 8th and 9th, and the full conference at Keeneland, the 9th through 11th. Academy Health coming up on the 25th and 26th. Again, abstracts for that are due on the 15th of January, and the NATO meeting in July 10 and 12. Abstracts for that are extended through this Sunday, the 23rd. So get your sharing session proposal in for the research track of that meeting if that's of interest to you. Lots of great things happening. So with that, we actually have a few minutes left for any remaining questions or comments or happenings in your networks that you might want to share with the group before we sign off for today. Well, hearing none, again, thanks everybody. Continue to keep us apprised as you've got research products happening. This is a challenging time. some of you may have seen that just again last night, the House filed a bill to kill the Public Health and Prevention Trust Fund again. I think this is the 34th or 35th bill that's been filed to try to remove that from the Affordable Care Act. So, you know, our research definitely has something to say in this policy arena about the value of public health, and we want to help you, you know, get your policy relevant findings out into this arena. So let us know if we can engage with you on that front, and we'll look forward to seeing everybody in the new year. Happy holidays and Happy New Year to everybody.
Thank you.
Same to you.
Same to you, Glenn, and everybody there.
Happy holidays.
Happy holidays.